Good morning, everyone. My name is Paul Glue. I'm a psychiatrist at the University of Otago in New Zealand. And I'm going to share some recent data from a phase 2 study looking at controlled release ketamine tablets in patients with treatment-resistant depression. First, I'd like to do a quick shout out to Rupert and Sarah and all their team for pulling this meeting together. I think it's a really important meeting and really appreciates all the effort that you've put into this. So some disclosures. The study was sponsored by Douglas Pharmaceuticals, a New Zealand pharmaceutical group, and I'm named on a patent relating to some of this research. I'd like to start my presentation with some really nerdy stuff, going back to first principles on how ketamine is administered and how this affects its pharmacokinetics. Many clinical studies and formulation strategies have focused on getting as much parent ketamine into the systemic circulation as possible. Now, this makes perfect sense if you're trying to treat pain or trying to anesthetize patients when you really want to have lots and lots of ketamine floating around in the bloodstream. However, I'm not sure that this is applicable if you're treating depression or anxiety. It's possible that strategies to increase exposures to ketamine's metabolites, specifically norketamine or hydroxynorketamine, would be much more important in this case, based on publications from the Maryland group, so Zanis and Moedel and other researchers. Now, staying with ketamine metabolite pharmacokinetics, I've got a figure up here from a paper which reported single-dose pharmacokinetics of ketamine and it's metabolized. This was published last year by a Swiss-German group. So they had developed a controlled release ketamine tablet and reported on ketamine and metabolite exposures after single oral doses. The two panels at the top of this figure are the R and S ketamine concentrations, and contrast that with the much higher concentrations and much more prolonged concentrations for R and S norketamine and R and S hydronorketamine. So really, the amount of parent that you're seeing in this situation is overwhelmed by the exposures to the active metabolites. So if the dosing strategy changes from how much ketamine can I get into the systemic circulation to how much of the active metabolites can I get there, it raises the question, for treating depression and anxiety, is ketamine basically just a prodrug? I've recently published on the influence of ketamine formulations and pharmacokinetic profiles on its safety and tolerability. There are over 40 ketamine formulation pharmacokinetic studies reported, the majority of which have included dosing of liquid ketamine via different routes of administration, various tablets and suppositories. And essentially formulations that maximize first-pass metabolism, generally by slowing down absorption, and which also delayed time to peak concentrations, reduced reports of dissociation and had much smaller effects on blood pressure. Unfortunately, we don't have enough published data to then look at, well, what's the impact on mood responses in depression or anxiety. Still, when we started the development program, we thought that a controlled release ketamine tablet could provide a safe and well-tolerated and also effective treatment option for patients with treatment response refractory depression. So I was very fortunate to have support from the formulation expertise of colleagues at Douglas Pharmaceuticals. They proposed making a controlled release tablet using a blend of polyethylene oxide and ketamine. So polyethylene oxide, the big pile of white powder in the middle of the slide, is a water-soluble polymer. It's widely used in manufacturing It's widely used in pharmaceutical development. And essentially, if you're thinking of making this at home, you take about 200 milligrams of polyethylene oxide and 60 milligrams of ketamine powder, blend it, put it in a tablet form, and anneal it at high temperature. This slide shows the effect of being immersed in water for one of the ketamine polyethylene oxide tablets. And so what I've done is lined up 2 shot glasses here. This one has water in it. This one is empty. And within an hour, you can see as the polyethylene oxide hydrates, that it forms a sort of slightly sticky mist. And as it's dissolving, it's releasing ketamine. And it takes approximately 12 to 14 hours for this process to be complete, so that we're getting a really very slow release of ketamine into the body. Now, the other advantage of this method of production is that the resulting tablet is incredibly hard, as I hope I'm going to be able to show you in this little animation. Come on, let's do it. Okay, that was a bit of a fail. Sorry about that. Essentially what happens in this little film clip is a hammer comes down and wails on the tablet about half a dozen times. And it basically is incredibly hard. It's well over 500 newtons in terms of surface hardness. And it's really impossible to crush. And I realized that beating a tablet with a hammer is not really an approved pharmaceutical abuse deterrent evaluation, but it does make it much less likely for this type of formulation to be diverted for abuse compared with a crushable formulation. We've subsequently run some single and multiple dose pharmacokinetics studies in healthy volunteers. And this figure here shows the concentration time profiles. The dark symbols at the bottom of this graph are ketamine concentrations, and the open symbols are the norketamine concentrations. So again, one can see a very flat concentration time profile for ketamine. And for a drug that in its liquid formulation has a half-life of 1.5 to 2 hours, we've got a half-life well into 8 hours or more, and we're getting exposures out beyond 24 hours. As we predicted in our review article, norketamine exposures were about 10 times greater than ketamine, which is evidence of very high levels of first-pass metabolism. And the elimination half-life was about 8 hours. And this is an example of flip-flop kinetics. Because you've got such a prolonged absorption phase, it spills over into the elimination phase, makes it appear as though there's a much, much longer elimination half-life. We saw minimal dissociation and no changes in blood pressure. The figure on the right is from a concentration time profile of an immediate release tablet from a 2003 Japanese study. And one can see that one's getting a much more marked peak concentration for ketamine, and then a rapid clearance, and that also norketamine is being much more rapidly cleared as well. So the delay in absorption and extensive first-pass metabolism that we're seeing in this phase here has a huge impact in terms of both exposures to the drug as well as safety and tolerability. We then completed an open-label repeat dose study of the tablets in 7 patients with treatment-resistant depression and social anxiety disorder. Now, I knew all of these patients well. I'd run them through studies using subcutaneous ketamine in my lab a year or two beforehand. The way we dosed it was to start patients out at 60 milligrams and they could titrate up to 240 milligrams based on mood ratings and tolerability. The reason that we picked this repeated dosing was based on some modeling to approximate blood levels estimated from ketamine infusions. And I've put the reference up to this Correll and Futter paper in Pain Medicine from 2006. Essentially what they'd done is they'd found 2 patients with treatment-resistant depression who also had chronic pain. They put them on ketamine infusions, and over 24 to 48 hours, not only did the pain go, but they got a sustained improvement in mood. And what I was hoping to do with the tablets was to approximate that type of exposure. So I've got 3 sets of mood responses here: the Hamilton Anxiety Scale, the Fear Questionnaire, which is looking at phobic symptoms, and the Madras. And just looking at the scores at time 0, so before starting any dosing, patients are sitting in a moderate level of severity on all 3 scales. By 48 hours, we'd seen either response or remission to on all scales in all patients. Now, when I'd previously given them subcutaneous ketamine, we could see a similar response within 1 to 2 hours. So the only disadvantage I could see with the oral dosing here is that we're getting a slightly delayed onset of response. So the next step in the project was to develop a phase 2 protocol to evaluate these controlled release tablets in patients with treatment-resistant depression. This is how we came up with the acronym Bedroc, and the inclusion criteria here are pretty standard ones for TRD studies. We had 3 phases in the study: an initial screening. Patients who were accepted beyond screening had a 5-day enrichment phase where they were given 120 milligrams each day for 5 days. We then looked at them the next Monday on day 8. And for patients who were treatment responders, so they had a 50% or more decrease in Madras score and had to have a Madras of 12 or less, they were then randomized to receive either placebo tablets twice weekly, 30, 60, 120 or 180 milligrams twice weekly. So open label enrichment phase. Non-responders were removed from the study at this point, and responders were included in the double blind phase. And the reason that we picked the dose range was that in a recent structured review on oral ketamine for depression, I think the first author was Blanc, this was the range of doses that he'd reported on. We had 21 centers enrolling patients across 4 countries, Taiwan, Singapore, Australia, and New Zealand. My last slide of this presentation is gives a shout out to the centers and the principal investigators who really did a superb job at enrolling this study. So this slide shows the early treatment response in the enrichment phase. So we've got day 1 where patients get their first tablets, and day 8 where we make the decision about are you a responder or not. So the mean Madras score before dosing was 31. By day 8, the mean score was 13. And overall, 73% of patients met response criteria. So again, if one were to look at this as comparing it against, say, SSRIs, this is a lightning fast activity. And again, although this wasn't specifically measured by day 2 or 3, most patients who are going to be responders are showing some measure of improvement. The primary efficacy endpoint was the change in MADRS scores compared with placebo. And for the 180 milligram twice weekly group, the difference was 6.1 points, and this was statistically significant. When we looked at the durability of the antidepressant effect, which is the relapse prevention part of the study, 70% of patients on placebo relapsed during the 3-month double-blind phase. Only 34.4% of people on 180 milligrams relapsed during the double-blind phase. And you can see that there's a dose response. As the dose goes up, the proportion of people relapsing decreases. Another way to look at the relapse data is with the Kaplan-Meier plot. And so the dose groups I've got listed on the side of the slide here. And one can see that for the placebo and doses up to 120 milligrams, most of the relapses are occurring in the first 4 weeks. Overall, we saw relatively little in terms of dissociation. Just to show you some data, we've got the CAD scores rated before people got their first 120 milligram dose on day 1, and then at 2 hours later. And there's quite a bit of scatter in terms of individual CAD scores in this pre-group here, and I guess as anxiety levels fell, there was less of a scatter, but the mean scores for both time points, looking at all people who went into the enrichment phase, was around 1 point, so very, very low. This is a summary of safety findings from the study. The most common events were headache, dizziness, nausea, and anxiety. And generally, these were of mild intensity. During the double-blind part of the study, we didn't see any particular issues relating to dissociation or bladder problems. These are standard safety evaluations, so suicidality, vital signs, safety labs, ECGs, and the BPIC bladder symptom ratings, and there were really no signs of concern with any of these scales. We did have 5 serious adverse events, 1 death, and 4 hospitalizations, and these are listed here by dose group. So trying to summarize all this, if we look at efficacy, we've got acute efficacy in 73% of patients with treatment-resistant depression based on 120 milligrams being dosed daily for 5 days. Now, albeit that this is open label, that this may be a rosy assessment of this, it's still quite a striking response. Once we'd selected these antidepressant responders, 180 milligrams twice daily seemed to have the greatest ability to maintain that antidepressant activity over 3 months. We saw very little dissociation, so it's quite different from, say, injected ketamine. And I guess there is still a debate in the literature. Do we need to have dissociation in order to get mood improvement? And I'd say if we look at the data from our oral dosing, that's not the case. The sorts of most common adverse events are listed here. They're generally mild, and none were limiting in terms of patients being able to remain in the study. And the important safety assessments that I've mentioned before, there were really no changes of concern. Another thing that we didn't formally look at, but certainly came out in in discussions with patients. The very early visits where there were lots of things going on. Most of the study visits were brief, and people could take tablets home to dose at home, and this was seen by patients to be very, very positive and acceptable. So the next steps are, we have a work underway to get a phase 3 program together, ultimately to support an NDA filing. And in terms of the patients who've gone through this study, almost all of them entered a 6-month open label extension study. And of those, we have 95 patients who've enrolled in a compassionate use program. And I hope by next year we'll have data from this to give you a sense of what maintenance treatment looks like, and what proportion of our patients may need this. And in terms of the people who really made this study work, the team at Douglas Pharmaceuticals were amazing. The nursing and medical staff at the 21 centres listed here did an incredible job at enrolling and completing the study and allowing further development of this formulation. Thank you very much.
Thank you, Professor Glue. Can you hear me okay?
Yep, come on, loud and clear.
Fantastic. Do we have any questions for Professor Glue? Yes, over here.
Hi there, Sagar Parikh from Michigan. So I'm just wondering if the patients, when they were in the long-term phase, twice a week, whether you captured a sense of intoxication, or how clearly could they tell what they were getting potentially a high dose versus low dose or placebo pill?
It's very. I think it would have been very difficult. During the enrichment phase, when people had very little experience with the ketamine tablets, they would occasionally get a sense of there's something slightly funny going on here. But again, it's a very different experience from, say, intranasal or IV infusions or sub-Q or IM dosing, where there's quite a striking change at about 5 or 10 minutes after dosing, and CAD scores will be in the 20s and 30s as opposed to sort of ones here. So I get your point. Was it possible that we saw unblinding? This is a pretty neutral formulation.
Great, thank you.
Hi, Celia Morgan from Exeter. It's sort of related to Sagar's question. Really lovely data, by the way, and it's a really amazing formulation. I'm sorry we didn't get to see you hitting it with a hammer. I was just interested in the dissociation. You concluded that dissociation wasn't necessary, but looking at the graph of subjective effects, it looked like dizziness and dissociation were the greatest for the 180 milligram dose. Could you look at that with this data to see if that was related to the outcomes?
I haven't drilled down into the data set that deeply. Look, I think it's a good point, and it's certainly something we can look at, but right now we're still really looking at top-line results.
Okay, we're going to take one more question for the audience from over here. Maybe at the back, Anya. Yeah, you. Sorry, everyone else. But...
Hi, I'm Anya Borisova from King's College London. So two questions. Do you have any evidence of tolerability? So kind of that people weren't responding even at the higher doses? And then kind of the counter side to that, any withdrawal effects if people stopped after a long time?
So again, I'm going to give subjective accounts of the 15 or so people that we've had through our clinic. If patients do show a response, and we titrate them up with twice weekly dosing rather than starting them with the daily dosing, it takes a lot longer. It takes perhaps 3 to 4 weeks before they start to notice an improvement in mood. So the mass dosing in that first week seems to be important. The second thing is that once patients have shown a response, it's very rare even during, say, 6 months or longer of maintenance, for them to lose that. I have seen individuals where we're dosing them, say, twice weekly. Most of them have wound up on 180 milligrams, where they'll get an end of dose phenomenon. So you've got a 3-day gap and a 4-day gap. And at the end of the 4-day gap, they're just starting to notice a reappearance of say, mood symptoms or negative thoughts. And for those individuals, we found that 3 times a week dosing, usually with 180 milligrams, keeps them reasonably well. Haven't seen anything that looks like withdrawal in the sense of, say, benzo withdrawal or alcohol withdrawal, or say venlafaxine withdrawal. I would estimate, though, that of the people who do show a response, and we are looking at a treatment-resistant group, I'd say ballpark 50% of people will need maintenance treatment to keep them well. That when you stop after 6 months, within, say, 3 or 4 weeks, the depression comes back, you restart them on the drug, and they're well again. You know, it's quite remarkable.
Great, thank you very much. There are some questions online. If you wouldn't mind, Sarah will be in touch, and you can maybe type out a couple of answers as well. But thank you very much. We're going to give another round of applause.
Thank you very much.
Thank you.